Welcome, everyone, and thank you for joining us on the South Sudanese Women Intellectuals Forum. Today, we will be having a discussion on women's health, and we'll be focusing on the topic of fibroids, which is a common gynecological issue in women. And we'll also talk about ovarian cancer. My name is Dr. Anne Lomole. I am a pediatrician and infectious disease consultant. I'll just do a brief introduction and then I will introduce our guest today, who for some of you, you know her, some of you don't, but I'll be introducing her later after introducing the topic. So we are focusing on ovarian cancer because we had discussed previously we had discussed other gynecological cancers, but I'll just give a brief overview of gynecological cancers, which are some of the leading causes of cancer in sub-Saharan Africa, and some of the reasons that are given for the high mortality and morbidity associated with this cancer is that there's delay in diagnosis and seeking of treatment within the region. And therefore, this leads to a lot of women dying from cancers that could have been treated early or even prevented. Now, even when they do present to the medical facilities, sometimes there's lack of specialized services, sometimes there's lack of medication, sometimes there's even lack of human resources that have the skills to treat them. And therefore, this delay between symptoms starting and seeking of healthcare results in very high death rates from cancer, because by the time they're presenting to the medical facilities, then they are completely worse off and they are at what we refer to as end stage. Now, in a country like South Sudan, where the healthcare system is already compromised because of the many years of war, and also the fact that the country is still trying to get back on its feet, then it's quite much worse off than the rest of the region. And it is difficult for diagnosis to be made early and also for treatment to be initiated. And therefore, when it comes to our country, then focus has to be put on the creation of awareness and on prevention of progression of gynecological cancers to end-stage disease. Now, we will discuss the epidemiology, the risk factors, prevention, diagnosis, and management of ovarian cancer. And then we will also encourage the men to be part of the discussion, because it is your sisters, your daughters, your wives, all the females in your within your environment who will be affected by some of these cancers. We're also going to discuss about fibroids, because quite a number of the ladies who are listening in during the previous discussion requested that we talk about that. And this is a common gynecological issue that is encountered in women of reproductive age, and has been a source of multiple health and non-health related issues in women. We are joined by Dr. Idioro, who is the first gynecological oncologist in South Sudan. And this is the second time we're having her on the platform in this capacity. We hope that this discussion will be able to educate on ovarian cancer and also able to educate you on fibroids. And we will also discuss some of the challenges and barriers to treatment management and also give some possible solutions. So we're currently streaming live on Facebook and YouTube, so join us on any of those platforms. Please feel free to post your questions on our Facebook page and we'll be able to answer some of them if time allows. And I'd like to thank the audience for joining us today. I would also like to thank the UN Women who have supported us multiple times during our discussions with internet, and I'd like to thank Aisha, who is currently behind the scenes giving technical support. Now, I would also like to thank Dr. Idioro for joining us today. I'll just give a brief biography before I welcome her. So Dr. Idioro Joseph is a practicing obstetrician and gynecologist. She's currently practicing at the Mater Hospital in Nairobi. She did her bachelor degree in medicine and surgery in the University of Juba and her master's of medicine in obstetrics and gynecology in the University of Nairobi. She's also a fellow of the Eastern, Central, and Southern Africa Obstetrician and Gynecologist Society. And as I said before, she's the first gynecological oncologist in South Sudan, and we are so privileged to have her on the platform today to share her knowledge with all of us. So thank you, Dr. Idioro, and welcome once again to the South Sudanese Women Intellectuals Forum. We are so grateful to have you here.
Thank you, Dr. Anne, for the elaborate introduction. I'm honored. Thank you.
Thank you so much, Dr. Idioro. So we'll just go straight into the discussion, and we will start by discussing fibroids, because quite a number of people were very concerned about this particular topic, because I believe it affects quite a number of women, and many people are unaware of what the genesis is, and probably have no idea about what management is done for fibroids. And there are a lot of myths that surround fibroids. So, Dr. Idioro, if you could please just set the stage by telling us what is a fibroid, or even explain a little bit in Arabic, if you can, for those who might not understand.
Okay. In Arabic will be a bit difficult, but maybe I will try. Fibroids are actually smooth muscle tumor of the uterus, and as Anne, you have said, it is more common in the reproductive age, and actually it is considered as the most common tumor of the reproductive age. And this means in simple Arabic, رحم في جزء من رحم عنده عدل. العدل ده هو فايبرويد ده بيطلع من عدل الرحم، لأنه الرحم ده عنده اتجاهات كتير. في part اسمه myometrium, they are whole part of the smooth muscle, and then there is endometrium also. This is a different part of the uterus. So in brief, هو أصلا جدا ورمة في عدل الرحم. Yeah, and epidemiologically, it actually occurs in about 30% of women who are above the age of 30 years old. And it is estimated that 20% of women by the age of 30, they already have uterine fibroids. But most of it is asymptomatic. So, يعني like 20% تا النسوان في عمر 30 سنة بكون عندهم لحمية، لكن ما بسهر في البداية. عشان كده الناس ما بعرف إنهم عندهم لحمية عالي. So, and the incidence is said to be about 3%. So كل مرة بكون في 3% ناس نسوان actually بكون عندهم لحمية. And again, epidemiologically, it is said to be more in black. So that means all of us who are black have higher risk of getting uterine fibroids. And it is said the prevalence is more actually in the ages between 35 to 45 years. And by the age of 50, it increases up to 80% of women would be having uterine fibroids. That's in brief epidemiology and what a fibroid is. Thank you, Anne.
Thank you, Dr. Idioro. 3 out of 100 is quite a huge number of women. The fact that you're also saying that by the age of 30, about 30% of women actually have fibroids, and it's asymptomatic, so it's difficult for someone to know. What are some of the risk factors or causative factors for fibroids? I think after that, then we can discuss some of those myths, because I believe people not understanding where fibroids come from or what the risk factors are contribute to some of the myths associated with them. So what are some of these risk factors or causative factors for fibroids, if any?
Okay. Some of the risk factors for fibroids include nulliparity, like somebody who has never given birth before, they stand a higher chances of getting uterine fibroids. Then obesity, yani those people who have good weight, more than the normal weight. And With weight, we attribute it mostly to the estrogen level, because with weight you have a lot of estrogen in the circulation due to conversion of the fatty tissue into estrogen. So again, the risk increases when you are black. And it is also said that the people who have given birth to many children, multiparity, they have reduced risk of uterine fibroids. So ده ممكن أنا بودي ل يعني مثلا في ناحية إنك كناين ورا نكن ما قاسم كلامت لحمية كتير ده لأنه شنو ما حتى أنا وحبوبت أنا كان رسو بدري وبرضو من ولد عيال كتير. So ولادة عيال كتير أصلا بيخليك تكون عندك low risk of uterine fibroid. Yeah, and again, it is said smoking reduces the risk of uterine fibroid, but I don't encourage you guys to smoke, but rather it's better to give birth to many children than to smoke. Thank you.
Thank you, Dr. Idero. For those of you who don't understand nulliparity, as Dr. Idero has said, those who have not had children or even who have children later are at increased risk of getting uterine fibroids. It seems that having many children is protective. Smoking apparently is protective, but of course, it also comes with many other health issues, and therefore, it's not something that we would propose as a prevention, a preventative factor. And then also obesity, and this is something that we can modify. You know, these are the things we call in medicine modifiable factors. So in terms of obesity, of course, if the issue is diet or physical activity, then that is something that has a solution for it. So obesity puts you at risk of many diseases. And now, from what Dr. Idera has told you, even fibroids is one of the things that it can put you at risk of because of the estrogen, which is the hormone that's mostly associated with females, that can predispose you to fibroids and even other cancers that we had discussed previously. So, Dr. Idero, are there some myths that you have come across when it comes to fibroids, especially in our society? What is it that people think is the cause of fibroids, or what are the myths that surround when a woman has fibroids? What are the things that the society says?
First of all, in our society as a South Sudanese, the number one thing is people start asking, will she give birth? Say mara da lindo lahmia de boile dutani, mara de ma boile dutani. So this is one of the myths that that is there. Actually, people think that somebody with uterine fibroid can never become pregnant or will never carry a pregnancy. That is actually not true, because it depends. Fibroid, the location of fibroid in the uterus is not all in one. The position is not one. So it depends on the location of the fibroid. Then it will be able to affect fertility. But this is only in like 5 to 10% of people with uterine fibroid, but the majority can carry pregnancy. I think we'll come to that later on to discuss on the effect of fibroids. And another myth is people think fibroids is cancerous. Not all fibroids are cancerous. The risk of a fibroid becoming cancerous is way less, like I think 1%. So it is, or even less. So fibroids are not automatically cancerous. Again, people think hysterectomy is the only effective treatment of uterine fibroids. يعني زول كان عنده fibroids لحمية طوال منفكر قال لك أنت لو رحم برا ده علاج للحمية، لكن لا they are ما definitive treatment for the fibroids. Again, people also think that fibroids only occurs for the people between 30s and 40s, in their 30s or 40s. Fibroids can even occur in people who are 50 years and above. And again, there is that myth that once fibroid is removed, it will never come back. Actually, fibroids, once they are removed, they can still come back as long as the main causative factor, which is estrogen, is still there. And people also think if you have a fibroid, it must be removed. That is wrong. Not all fibroids are supposed to be removed. We assess the situation where the fibroid is, then we can say whether this is a fibroid to be removed or not to be removed. So if zol kanin do lahmia ma dururin do lahmia de lazim bitalao. Fi lahmia tanin bitalao, fi tanin ma bitalao. Again, the other last myth that I've come across is that when you take some medication, it will dissolve the fibroid. And I found some clients taking herbal medications from China, the Chinese herbs, that they actually make the fibroid to disappear. These are all wrong myths, and we should not take it, because fibroids are never removed by medication, and they will never disappear with medications. I think these are some of the myths, unless you have some and you can add.
Well, I think that one is quite a wide array of myths that you have mentioned. The one I've had is more about the fertility one, but I'm glad that you've explained that it depends on where the fibroid is. We'll get into that a little more later. I'd like you to probably mention for us, you said that most of the fibroids are asymptomatic, but what are some of the signs or symptoms of the ones that are symptomatic, and how are they how do you diagnose a fibroid, especially an asymptomatic one? What do you do in terms of diagnosis?
Okay, most of the asymptomatic fibroids are usually diagnosed on ultrasound, which are actually coincidental. Yani masalan zorwa le amul moja le sabab tani. Well, most of the time during pregnancy, yani zol hamil ukura amul moja ta himil fi fatrat al-himil ala badak bainu gali aslan fi lahmia. These are most of the time they are incidental findings when somebody does a scan for another reason. Now the ones which come with symptoms, the most common symptoms for uterine fibroid is actually vaginal bleeding, which is actually one of the commonest symptoms, but now the bleeding is during the menses. So people should actually differentiate. When you are having other bleeding between the periods or between the cycles, mostly it is not related to fibroids. So the vaginal bleeding, which is associated with uterine fibroid, actually are heavy menses. So like Zolkanin Dodora, the flow will be too heavy. Yeah, this is most of the time this is what happens. And again, when the fibroid is like inside the endometrium في داخل الرحم, so sometimes بيحصل low inflammation, بيحصل ulceration. Then after that one, this ulcers can shed, and then this one also increase it has the infection, and again infection makes the periods very heavy. And at the same time, when it is inside the uterus, it makes the uterus not to contract during menses, and then you get also heavy menses. And again, at the same time, when the fibroid is so big, you can get congestion. So Zol we feel like the pelvis is so congested, and you feel bloated, and all these symptoms you can also feel. And again, there can be endometrial polyp, which is associated with a fibroid. So again, sometimes you can feel that there is something coming out of the vagina. So now, if it is again a polyp which is prolapse, so you can get a contact bleeding. That is when having sex, you can also get bleeding during sex due to fibroid. And again, there can be discharge at the same time. Like I said, when the fibroid is inside the uterus, then it gets ulcerated and secondary infection. There can be also foul-smelling discharge. If razad barabi, marad bokon min fibroid. Then again, masalan sometimes somebody comes and thinks that I normally have heavy periods. Then when they come to the hospital, they are checked. They come with other symptoms of anemia. Then when they are checked, they are found to be anemic. So even fibroids can present as iron deficiency anemia when somebody doesn't know they have fibroids, but they have heavy periods, which they think is usually is normal. Then other clinical presentation, again, somebody can present as infertility. And infertility, like I said earlier, is only in 5 to 10% of women with the fibroids. And again, when a person comes and has a fibroid and primary infertility or any type of infertility, we have to look into the other predisposing factors like anovulation or hormonal disturbance. We exclude those ones before we conclude it is a fibroid. Because the fibroids which can cause infertility can include the fibroids which are like masalan fibroid في اتجاه tubes. This one can cause tubal blockage. And of course, if the tubes are blocked, you can get infertility. Again, when a fibroid is inside the uterus, in the endometrial cavity, again, it acts like a foreign body. So again, there is less chances of implantation. And at the same time, the fibroid that can cause infertility, masalan, if the fibroid is very low at the cervix, then again, it causes cervical obstruction. So there is no chances of the sperm swimming upwards. So, and again, fibroid can be presented with a pain, which is very uncommon, but it can also happen. And some people can also present with a lower limb swelling. This also depends on where the fibroids. If the fibroids presses the pelvic vessels, again, that one reduces blood flow to the lower limb. And somebody can present with a lower limb swelling. Yeah, I think I've exhausted most of it, unless there is anything else, and you can add.
Thank you. I think that's very exhaustive. I'll just give you a comment from the audience as we go now into some of the management strategies that are used for fibroids. So Veronica says, I had fibroids when I was in my 20s and had a laser procedure to remove it, but it seems not all of it died off, because the last time I did a scan, it showed it's still there. But the doctor said it's nothing to worry about since it's small. So what she's asking is whether this will cause problems in the future and whether she should have it removed and whether she should worry about it. So as you answer that question, you can also even go into further details on how fibroids are managed in terms of treatment strategies.
Okay, my answer to Veronica is I would like to know how old is Veronica now, and whether Veronica has completed her family size. This is also another consideration that we will consider in the management of fibroid. Your age at the time, your family size, and then again in the evaluation, we have to make sure where the fibroids are. And then from your history, again, we'll have to consider whether it is really affecting your day-to-day activities. If like the bleeding is a lot, the periods are heavy, because again, heavy menses will lead to anemia, and complications of anemia are far worse than doing surgery for fibroids, because anemia can lead you to heart failure. So these are all the things that can be considered. The location of the fibroid, number one, and if you still want to have more babies, because this one will also determine whether we are going to remove the fibroid and the size of the fibroid at the same time. Like I said earlier, in the myth, people think like once fibroids are removed, they will never come back. They will still come back as long as the uterus is there and the estrogen is also there. I don't know, Anne, if I've answered that question for Veronica well.
I think to some extent you have. Of course, we need more details, but I can see she has also written there that she's managed to have children despite having the fibroids there. And it's been over 10 years since they were first diagnosed. So, of course, when it comes to medicine, this is for the audience. There are many factors to consider before you decide, okay, this is the treatment we're going to do for this specific individual. So some of the management is actually specific depending on the person you're dealing with. And as Dr. Idioro has said, you have to ask what is the age of the person who's talking about, who's come to you. Have they had children? What is their desired family size? How big is this fibroid? Where is it specifically? You know, what are the symptoms that it's causing? So you have to look at very many factors before you decide that you're going to do any specific procedure or you're going to treat a certain condition a particular way. So it's sometimes individual, it's individualized, you know, depending on various factors. But thank you so much, Veronica, for that question. I hope we have answered you, and I hope that if there's something that's not clear, you can always reach out to Dr. Idioro. She's available, and we can share her contact. You can also contact her on Facebook, on Messenger. Sandy Zane, on the other hand, has said she had fibroids and adenomyosis and endometriosis, and apparently the only treatment she could get for those is to stop the periods. She says she's in constant pain, and she didn't want her period being stopped, as she felt it would affect her fertility, and she's requesting for advice. So I can see people want you to answer their question. So let me just allow you to answer Sandy on that. I don't know whether you got the question, Dr. Idioro.
You just come back again, Anne, for that question. So, she has endometriosis.
So she says she has fibroids, adenomyosis, and endometriosis, and she was told the only treatment is for her periods to be stopped. And she says she's in constant pain. She doesn't want the treatment of stopping her periods because she's scared it will affect her fertility, and she's asking for some advice from you.
Okay. Endometriosis is on itself a big topic, and most of the management for endometriosis, because of the severe pain, is actually the stopping of the menses most of the time. And unfortunately, endometriosis at the same time causes some adhesions in the pelvis, and that is most of the time the cause of the severe pain. Yeah, but concerning fertility, with I don't know how big the fibroids are, but concerning endometriosis, so the priority will go when you are ready for to get her babies. So you need to see a fertility specialist who can assist you to achieve pregnancy, because most of the time with the adhesions, again, you get infertility because of adhesions that is caused as a result of endometriosis. And the reason why the periods are being stopped with endometriosis is to reduce the inflammatory process that is being caused by the endometriosis during menses. So again, I will maybe request you to side chat send me an SMS, then we can maybe chat on that, because it's a bit complex.
Mm.
Yeah.
So, Sandy, you've heard from Dr. Idioro that she is willing to have a further discussion with you. So you can either contact me directly, and then I can share her number, or you can also contact her on Facebook, or contact her through the page. I hope to some extent she has answered your question. Dr. Idioro, before I read out some of the other comments and questions that people are sending on the platform, apart from surgical intervention, what are the other methods that, as obstetricians and gynecologists, what are some of the other things you do when it comes to management of fibroids?
Okay, management of fibroids, like I've said, the number one management of fibroid is actually conservative. Like we have already seen, most people actually have fibroids which are asymptomatic. So we do conservative management for the very small fibroids which are asymptomatic. And again, conservative management for fibroids can be done when they are seen during pregnancy. And it's just observation, and which can also be done like every 6 months if sometimes there are symptoms and we are not in a position of removing the fibroids because of other reasons. Yeah, then we have a medical management for fibroids, but usually these are hormonal therapy which are being given for, like, if a fibroid is so big and the surgeon feels that we need to reduce the size of the fibroid before going in for surgery to remove the specific fibroid, then we have to give the medical therapy just to reduce the size of the fibroid, because it can be the definitive treatment. Once it is stopped, again the fibroids start growing again. So again, when a patient is near menopause, so when a patient is approaching menopause, again, you can give medical management to reduce the size, because actually when the patient hits menopause, now there is no estrogen in the system. So the growth of the fibroid actually reduces, and it will not continue to grow, although it will be there. So as long as it is not growing and the person is in menopause and there is no bleeding, so there is no point of removing the fibroid, even if they are big and they don't have any symptoms. So again, it is also said that a newly married person with uterine fibroids and minimal symptoms, again, because we want to give them a chance of seeing whether they'll be able to conceive with the fibroids and complete their family size before you interfere with their uterus. Yeah, and again, in pregnancy, we don't remove fibroids, because again, you might interfere with the pregnancy. Now, when we come to surgery, the indications for surgery will include, like, if the fibroids are symptomatic, like I've said earlier, it interferes with your daily activities. Or again, for big fibroids which are actually big and showing that the abdomen is big, is distended, and for most of the time that we call a cosmetic reason, because again, as a lady, you don't want your tummy to be showing all the time when there is no pregnancy in it. And again, we go for surgery when you suspect that there is malignant changes, like you feel like maybe it is becoming cancerous. And this one you assess with the fibroids which are really growing very fast in a very short time, or a fibroid that is really growing in a person who is already menopausal. Now, again, at the same time, you go for surgery when there are multiple huge fibroids, and which can also risk complications to the patient. So I think these are some of the reasons why you go for surgery for fibroids.
So thank you for that, because you have just at least been able to tell us that for those that are asymptomatic, you leave them alone. It's conservative management. And for the younger affected individuals who have not yet had any children, if it's not interfering with the uterus itself, then you leave it alone so that they can have a chance to bear children before any management is done. So thank you for that, Dr. Idira. I think you've explained quite well. Now, for those who end up having symptomatic fibroids, what are some of the danger signs that are seen, and what should women who have been diagnosed with fibroids watch out for in terms of when they should now seek medical intervention, especially if they were on conservative management before?
So first of all, fibroids that have shown suddenly in a postmenopausal lady, it was there, then it has become very symptomatic in menopause. This is one thing that will raise an alarm for the fibroid actually to be removed, or this is a danger sign for the individual to immediately seek medical attention. Again, if you have a fibroid, like I said earlier, and then between the menses, you are getting bleeding in between. This intermenstrual bleeding actually should also raise an alarm. That means there is something else which is causing that, not the fibroids. So this is actually something that will ring a bell for a person with a fibroid to seek medical advice. And again, if the abdominal distension is rapid, or suddenly you are seeing the distension is coming up very fast, also this is also one of the danger signs. And again, a fibroid which is compressing on the ureters. So because the fibroid, maybe it can be big and it can press on the ureters, and this cannot actually lead to renal failure. So fibroids which are on the ureters, again, this one can raise an alarm for that fibroid to be removed to prevent the person from getting renal complications. Yeah.
Oh, interesting. The renal complication part. So these are basically pressure effects of fibroids, where they lie on important organs or parts of organs, and then cause further complications associated with that. So we have to be very careful when it comes to the really large fibroids that are in locations that are affecting other organs in the body. So, Dr. Idiro, as we go to the next question, I'll just read something Dorcas has written here. We know that fibroids have both health and non-health consequences, which you had started discussing, especially the infertility part. But before we get there, Dorcas has asked, she's saying, Dr. Idiro, thank you for this discussion on women's health. My question is, what could be the cause of infertility in a woman who has had her child, her first child, and now 8 years later has not had children again? I know it's a bit off topic, but maybe you can say a few possibilities. So 8 years ago, this woman had a child, but after that has been unable to have another child. What are some of the causes you might be thinking of, Dr. Idiro?
Yeah, I think for this reason, this one we call secondary infertility, but we'll have to go back to basics, and then we start from the history after the first delivery. What happens? What are the symptoms that she have? Are the periods still regular or not regular? Because maybe the periods are there, but she's not ovulating. Then we can still do hormonal profile, but usually first thing first, many causes of infertility are associated with tubal factors. So we'll have still to check for the tubes, and then again we have to consider where there was infections. Now the last delivery, how was it? Was it cesarean, normal delivery? After delivery, was there infection or no infection? Risk of STIs, were they there? Because these are all the factors that can lead to tubal blockage. If these ones are not there, then we go to the next one, because we have to evaluate the tube first. Then we can go to the next step and assess whether the menses are normal, the same one. And again, another thing we have to confirm, is it the same husband? So because if it is a different husband, then again we'll have to go back and reassess the new husband. Yeah, maybe again the period is because of a sperm issue and not actually the lady. But if it is the same husband, again we'll see if the husband has other children, and the youngest is how old. So it is a bit of a process, and then we have to get a better history for us to know where the problem is. Yeah, because now the management will be all different. Yeah.
Yes, doctors, I hope that answers your question. I'm sorry, it sounds like us doctors are always, we seem to be going round and round and round, but the truth is that there's nothing that's ever straightforward. And as I said before, it's all about individuals and what the individual history is and what you find when you examine the patient. And that's why it's very difficult for doctors to even practice from a distance, because we have to get to know the patient so that we find solutions and we are able to diagnose that specific patient. So it's quite a complicated thing, and of course we would need to know all those things that Dr. Idioro has mentioned to be able to now narrow down to what might be the cause of infertility, but those are also the possible causes that she has mentioned, from infection to blockage of the tubes to a different partner who might actually have issues with the sperm. So quite a number of things can lead to secondary infertility. Now, Thok Port Teny has said this is a very important topic, and he would like more of such discussed. Kawach Deo has also said this is a very nice topic. Dr. Marial Sikom has also said he's quite impressed and he's very happy about this topic. Thank you so much. These are all gentlemen. Thank you for watching, and please share this discussion with the women in your life and with anyone who might be interested. Now, to just wrap up the discussion on fibroids, Dr. Idioro, apart from the few that you've talked about, what are some of the health and non-health consequences of fibroids, and how can this be prevented or managed?
Okay, I will just summarize it. The health and non-health consequences of uterine fibroids. Let's go to the cost of treatment. Actually, it is very costly to treat a fibroid. Like in the US, it goes to billions of dollars per year to treat women with the fibroids, because of course we know medical care is very expensive there. And again, like if a woman, like let's say 3 women in the same office have uterine fibroids which are symptomatic. So if you calculate in terms of the number of days of absenteeism from work, so this is actually economically, it will also affect where they are working, because they will not be able to perform their duties as required. And yes, due to less productivity, again, I think it will affect our economy. I think this is in summary. Yeah, thank you.
Thank you so much, Dr. Idioro. I know you had already mentioned all the other things that fibroids can cause, including infertility and anemia, and if they press on the ureter, which is the part that takes the urine from the kidney to the bladder, that can even lead to liver failure. So there are quite a number of health consequences depending on the size and the location of a fibroid, but also the non-health consequences are things that we should not ignore, because it decreases productivity and it also really costs both the society and the nation to treat fibroids. So we'll just jump on to our next topic. Ayor Makur is saying this is a very good topic, and he's very thankful that it's being discussed. So we'll just move on to now ovarian cancer, which we had said we would discuss after our last discussion on gynecological cancers, because we ran out of time. And the focus of ovarian cancer was basically because, of course, we also have to consider those who may have experienced it or might be going through the same. So Dr. Idioro, if you could just explain what is ovarian cancer and what is the ovary for those who don't know. And maybe also now tell us a bit about the epidemiology of ovarian cancer, whether in Africa, the world, if there are any for South Sudan, and why the difference. Dr. Idioro.
Okay. Ovarian cancer in simple terms is just a growth in the ovaries. Ovaries, بعربي ده هو بويدات. I don't know if I'm pronouncing it the right way, but they are بويدات. So مثلا كان حصل فوقه cancer cells, they are occupied by cancer cells, then they develop into ovarian cancers. So the epidemiology of the statistics of ovarian cancer, it's actually the 6th most common cancer in women worldwide. And the rates of ovarian cancer actually in East Africa are among the lowest in the entire world. So, but in North America, it is said to be the leading cause of gynecological cancer and death. And but for us, it is otherwise the cervical cancer, which are the leading cause of cancers in our setting. So ovarian cancer actually represents about 30% of all cancers of the female genital organs. And in developed world, it's about a common cancer, like the uterine cancer. And like I said, for us is usually the cervical cancer. So the incidence of ovarian cancer actually varies from 2 per 100,000 cases to 15 cases. That is now when we come to Africa. So like when you get the 2 in 100,000, that is in Africa, and in 15 that is now in the American Eastern Europe, because they are more higher at risk of ovarian cancer than us. So, and also it is said in other countries like New Zealand and Australia, the risk of ovarian cancer is also much higher. So at least for us, it's the risk is a bit lower, although we also have the burden of other cancers. Yeah, when we go to survival of ovarian cancer, again, the 5-year overall survival is about 38%, which is actually very low. Yeah, I think that is all that I can say. And maybe I can just add, ovarian cancer has different types, and we also have ovarian cancer that occurs in infants and young girls. So ovarian cancer is not only the disease of the old women. So there are also ovarian cancer, although the risk is much less in children. Yeah, thank you, Anne.
Okay. Thank you for that information, Dr. Igiro. Is there any reason why it seems that in Africa we seem to be less at risk for ovarian cancer, or does it have to do with the fact that maybe diagnosis is not made early enough, or people don't even come to the hospital for that diagnosis to be made? Is there any reason why it seems to disproportionately affect Western countries versus this continent?
Okay, now when we come, I think when we get to the risk factors for ovarian cancer, that is when we will be able to relate why ovarian cancer is more in the industrialized countries than in Africa. Because again, the risk factors for ovarian cancer.
Yeah.
Pardon?
Go ahead with the risk factors and the causative factors for
yes.
ovarian cancer.
The risk factors for ovarian cancer again, nulliparity, like people who have not given birth, and we know in Africa we are good at giving birth. So like in the industrialized countries now, most of the time, most of them don't give birth early. So and most of them can give birth only to one child. This also increases the risk of ovarian cancer. Again, infertility also increases the risk of ovarian cancer. This is because you are always ovulating, but then there is no way of giving the ovaries rest. So the ovaries are always at work. And again, we can correlate that because one of the risk factors, again, early menarche. When we see in the industrialized countries, I think the children grow very fast, and most of there is that risk of obesity, and there is early menarche than in Africa, where there is a lot of hunger, and people can even the girls can get to menarche maybe after 15 years. Yes, and the earliest is 12, while in the West, girls can get to menarche at 9 years or 10 years, very, very early. So this one also increases the risk of ovarian cancer. And again, we have another risk, which is genetically. So like there are some chromosomes which are called the genes which are called the BRCA. So this one also increases the risk of ovarian cancer, and there are some syndromes like Lynch syndrome. Also, these are things which increases the risk of ovarian cancer. And most of the syndromes, we don't have them actually in the Black population. Yeah, again, family history. This is also one of the risk factors for ovarian cancer. So once there is someone in the family who had ovarian cancer, so there is high risk of the others getting the same cancer. And these are where we always encourage the rest of the family to be screened. Again, there is a risk which is associated with smoking, increases the risk of ovarian cancer, and diet. This all comes to obesity and peripheral conversion of estrogen. Yeah. And again, like Anne, you said earlier, we have exercise.
Dr. Idero, your mic is muted. Your mic is muted. Go ahead.
Yes. So like exercise, lack of inactivity, again, at the same time also increases the risk of ovarian cancer. So I think I would just encourage all our South Sudanese women to be actively exercising, because from our previous discussion and even today, I think exercise plays a big role in reducing the risk of cancers. There are also some protective factors which can reduce your risk of getting ovarian cancer, like use of combined oral contraceptive pills. And this comes with the fact that it keeps the ovary to rest for some time. So actually, if somebody has used the combined oral contraceptive pill, it's safe like for 5 continuous years, that reduces your risk of getting ovarian cancer by 50%. And again, the type of family planning, which is tubal ligation, reduces the chance. And breastfeeding reduces the chance. And I think in Africa, we really breastfeed. So I think I will encourage everyone to breastfeed, because again, you have seen it also protective against ovarian cancer and multiparity. Yeah, when you have more babies, again, you have less chances of getting ovarian cancer. Thank you.
Interesting. I think it's quite clear now why the Black population is not as affected by ovarian cancer versus the West, and it's good that you're emphasizing on the factors that we can modify. Okay, the fact that obesity is one thing that has featured in both fibroids and in ovarian cancer gets us thinking that physical activity and fitness and diet control is a very important aspect of actually preventing multiple diseases across a wide spectrum, whether it's gynecological, what Dr. Idioro is talking about today, or even what we call lifestyle diseases. So it's very important to look into some of these factors that we can modify and sort of protect ourselves from getting some of these conditions. Now, how do gynecologists screen for ovarian cancer? What are some of the signs and symptoms, and how is the diagnosis made when it comes to ovarian cancer, Dr. Idioro? Your microphone is on mute, Dr. Idioro.
Sawa.
Thank
So
you.
the diagnosis of ovarian cancer, maybe we can go through the screening first, then we go to diagnosis, or you want us to go through the diagnosis first?
We can start with screening and then we can talk about the signs and symptoms and then the diagnosis.
Sawa. So screening for ovarian cancer is usually through imaging modalities that we have, like most of the time is ultrasound, which we do to check the size of the ovary and what the ovaries has. Like if the ovary has a cyst, then actually at the same time, this one is assessed how the cyst, through the ultrasound, how the cyst looks like. If it is a simple cyst, of which a simple cyst, many people have a simple cyst, and that is where we always get a problem with the patients who come and they are done a scan, and it is the report comes out that there is an ovarian cyst. So people get worried once they are told there is ovarian cyst. There are many types of ovarian cysts. So simple cyst is common, like any woman in their reproductive age. If they are done as an ultrasound, almost 80%, more than 80% will be having the cyst. These are called physiological cysts. But then to get the cysts which are abnormal, now the scan will be able to show us whether the cyst is complex, what it has inside. Sometimes they will say it has some like sticks within the cyst, and they will say the cyst, the water which is inside the cyst is not clear. So this one is a complex cyst which we will need to screen further. Then again, we have a hormone that is most of the time associated with ovarian cancer. Again, this one we can check that hormone, which is called is a tumor marker actually, and we call it a CA125. Then these are some of the screenings that we do. And then like if we do the scan and it shows the cyst is not a simple cyst, it's a complex cyst, then we do that hormone level, the CA125. Again, at the same time, we go back to the drawing board and see where the patient lies on. Is the patient menopause, post-menopause, or premenopause? So these are all the things to consider during screening for ovarian cancer. And most importantly is, again, the clinical examination, whereby the patient has to be examined so that we see whether how big the cyst is it painful when it is being touched. And then again, at the same time, we do this abdominal examination, and again, we do vaginal examination. These are part of the screening, because some of the time you can find the cyst when you do a vaginal examination, and you will feel maybe they are in the posterior part of the uterus. Yeah, I think these are some of the screening methods that we do. And again, we can go to genetic screening, which we screen for the genetic factors. And this one we have, like I mentioned earlier, we have the gene which is called the BRCA gene. Now this one, if we have a family members who had ovarian cancer and then breast cancer, so most of the time these things occur when they are less than 45 years. So we go back again to the history and ask whether there is a family history of ovarian cancer. In somebody in the family, we call it the first line family, who have an ovarian cancer or a breast cancer when they are less than 45 years old. So this one brings to suspicion that there is a family link. So it is most likely genetic. Then these ones we increase our we screen them for that gene, and we encourage all first line relatives to be screened. And again, at the same time, when this one is also noticed in the family, we all encourage the girls in that family to have their families early. Before the age of 35, you complete your family size, then we do the radical surgery, which is prophylactic surgery or protective surgery, whereby we remove all the ovaries, and even the breast can also be removed. Yeah, I think these are some of the things. And again, we have the what we call there is also another gene which is called HNPCC, which affect again breast, ovary, and colon. So again, if we get a family member who had a colon cancer, first degree member of a colon cancer, now again, this also raises a suspicion that this family must be having that gene. So we have also to screen. Yeah. So
basically, those with a family history of breast cancer, colon cancer, or ovarian cancer have to be very, very consistent with screening and actually getting themselves checked. And also, in case they have that kind of history, then it would be good to have their families early. I think that's very important information for those who have relatives who are affected by the same. Thank you for that, Dr. Idioro. Now, in terms of some of the signs and symptoms to watch out for, what are these for an individual who might think there's something going on there? And I want to know what it is. What are some of the things that they might experience before you do the scan that might be indicative that there's that they have ovarian cancer or a mass in the ovary?
Okay. Now, by the time somebody gets some mass, actually, that one now is obvious, and there must be symptoms. But most of the time, the presentation of the symptoms of ovarian cancer are not specific. They are non-specific. So most of the time, they come with GIT symptoms. Like most of the time, they have dyspepsia, Zolindo-Haragan throughout, and the additional ulcer. Yes, zol kengalo wendo gurha. Gurha kamana la masalan kanamul investigations le gurha de mafi haja. I think the first suspicion should be for ovarian cancer, because most of the time people get to take these antacids for very long time, and keep on going to the physician, to GI physicians. They are done endoscopy, colonoscopy, and all these things, and there is nothing. And so when somebody has these symptoms, I think it is always good to go further and look for ovarian cancer. And again, to my doctors, colleagues, if a patient keeps on coming and non-specific GI symptoms, and you have done everything, there is nothing, and if she's a lady, kindly refer to gynecologist, because most of the time this is how ovarian cancers present. And ovarian cancer again can present as a surgical problem. Again, our colleagues in surgery. So if a lady comes with like intestinal obstruction, because this is most common with ovarian cancer, I think also let this one click into our mind that most likely it can be ovarian cancer can be the cause. So again, like I said, this vague abdominal discomfort, and if the mass actually again the ovary presses on the bladder, again somebody can just present with symptoms of for the urinary tract, like urinary frequency, or can even present with a pelvic pressure. Now, like Anu said earlier, if it becomes now a mass in the abdomen, so this is a high index of suspicion for such a person. And especially when the woman is at the age of 40 to 69 years old there, I think let this one actually ring to our minds. Now we have the common presenting symptoms in Kenyatta National Hospital, where I practice. Most of them, they come with abdominal pains, and this is about like 8%. And those who come with actual abdominal swelling and pain are more, up to 15%. But majority of the patients, they come because of the abdominal distension. And obviously, when the abdomen is so big, that means the cancer is actually advanced. And some few patients can present with vaginal bleeding. So if a person like mostly between the ages of 50 years and above, they can present with abnormal vaginal bleeding because of the type of the ovarian cancer. Now, as I said, all the cancer is not all the same. So there are different types of the cancer also present differently. Yeah, but the most common cancers for ovarian cancer in adults is epithelial ovarian cancer, which actually present with these symptoms that I've explained. Thank you, Anne.
Okay, thank you for that. Thank you for that, Dr. Idioro. You talked a little bit about the radical surgeries that are done in those who've had relatives with the same and who've completed their family size. Now, for the rest who may be diagnosed with ovarian cancer, what are some of the treatment strategies that are used for those who have been diagnosed? And what's the prognosis? Like, what happens after? Do most of them survive? Do they get a cure? What is the prognosis? Dr. Idioro, you're on mute. You can just unmute yourself. Yes, thank
Okay,
you.
sorry, my cursor just decided to hang. Okay. Now, for most ovarian cancer, the mainstay treatment is actually surgery. So once you are diagnosed with ovarian cancer, the first line of treatment is actually surgery, which is then followed by chemotherapy most of the time. And the surgery usually includes removal of both the ovaries plus the uterus and the cervix. So when someone is diagnosed with ovarian cancer, the first thing that comes is we are going to do the surgery, which will include removal of both ovaries, uterus, and the cervix, and even some of them. There is that part of the intestine which is called omentum. So most of the time we remove part of that omentum with it. So it is actually a radical surgery. And this one actually occurs when the cancer is early. So when the cancer is early, this is the radical surgery that is being done. Because again, most of the time when the cancer is a bit late, you will not be able to remove everything. But you are advised to remove whatever you can remove, or whatever you can see. So sometimes you can see, but you are not able to remove because of the complications, maybe the adhesions to the intestine, so you will not be able to remove everything. But once ovarian cancer is diagnosed early, then this is the radical surgery, which is being done, and then this will be followed by chemotherapy after. And when the presentation is a bit late, and from the imaging that has been done, and you know that this is going to be a very difficult surgery and you might not be able to remove everything, so we give chemotherapy before surgery, and this we call it as neoadjuvant chemotherapy. You give it like at least 3 cycles for the cancer to shrink, to become a bit smaller. Then you go and do the radical surgery that you will be able to do. The maximum effort, actually, that is what we call. Then after that, you continue with the chemotherapy. Again, on the same line, now there is that patient who came very late, and then you will not be able to do much, but we will do what is called a palliative treatment. Palliative treatment can be only chemotherapy, because this patient cannot withstand theater, cannot go to for surgery, or you might end up losing the patient in theater. Then you can give this palliative chemotherapy. But if again, comes with the symptoms of obstruction and dyspnea, and the patient is not able to breathe, then again you go for surgery, knowing that you are just doing a palliative surgery. But actually you are not treating, but you are relieving the patients from the symptoms. At least what we always say, it is a quality of life. Even if the patient is any stage cancer, you need the patient to die free of pain, and the quality of life to be a bit better until the patient dies. So these are actually the treatment strategies that is done for ovarian cancer. Now, the survival for ovarian cancer is about 70% for 1 year. For most of the patients, 70% for 1 year or more, and 45% can survive for 5 years or more, and only 35% can survive for 10 years. But this one all depends on the type of cells of the cancer and the stage of presentation. So the earlier you present and the type of cells are less aggressive, and the response to the chemotherapy. I know people always say once you are given chemotherapy, you will die. But this is not always the case. So most of the time people respond well to chemotherapy. So your response to chemotherapy actually, and your response to chemotherapy, your stage at presentation, this one's also determine your survival. Yeah. But most of the time, patients with advanced cancer, advanced ovarian cancer, actually the survival is 10 to 18 months. Yeah, sadly. Thank you.
Okay. Thank you for that, Dr. Idioro. I know you've talked about radical surgery, even in those who have like a family history of the same. Are there any other preventative methods or things that are done to prevent ovarian cancer from developing in those at risk, or that is not something that is possible?
I can say yes and no at the same time. It is yes, like I've explained in the familial type of ovarian cancer. This one actually most of the time can be prevented, because we already know this this group of people, they are carrying the genes. So these are what can be done for all the girls in that family. So this one can also be prevented. But for the other group, because now we can't screen the whole population for ovarian cancer, because actually the benefit of the screening for a whole population for ovarian cancer doesn't actually match the benefit that we will get out of it in terms of economically. So, and again, at the same time, it can just increase anxiety if we say we are screening the whole population for ovarian cancer. Like I explained earlier, we have simple cysts which exist everywhere for most of the women at their reproductive age. So again, this will increase more of the anxiety, and it is not cost effective. Yeah. But again, I will still insist on routine checkup Once you do routine
Thank you so
checkup,
much, Dr. Idioro. I'll just read some comments from the audience. I end. Oh, sorry, Dr. Idira, I interrupted you there. So you were talking about routine checkup as being an important way of getting people diagnosed early, and also in terms of prevention, also getting that done. So I'll just sort of mention some of the comments from the audience. So Ayan Deng is saying that exposure to certain environmental agents may increase risk of ovarian cancer at some point. I don't know what your comment is that about that. And also saying that this is a great topic, and they're very grateful for the education that is being given to the audience. Yeah, quite a number of people saying thank you so much for the information that you're giving them, Dr. Idioro, and they're quite happy that this is a topic that's being discussed. Now, Ayan is also saying that ovarian cancer is the fifth leading cause of cancer among women in the US. And Rosemary on this side has taken us a little back to fibroids and is asking, is it medically proven that birth control medication can lead to fibroids? And can fibroids lead to premature labor? I think you can answer that in 1 minute, Dr. Idioro. Whether she's asking whether contraception can lead to fibroid, and whether they can lead to premature labor.
Maybe contraceptives, it depends. If it is estrogen, like we said, estrogen actually increases the risk of uterine fibroids. Yes, that is estrogenic contraceptives. But then again, when you come to premature labor, no, fibroid can fibroid lead to premature labor? Yes, fibroid can lead to premature labor. It depends on the size of the fibroid and the location of the fibroid. You know, if the fibroid is again very big, actually it will increase the size of the uterus, and that one over distension of the uterus can actually cause premature labor. Yeah.
Thank you for that, Dr. Idioro. I think you've answered what she was asking, and yes, I hope that information is okay for you, Rosemary. Someone also asked a question before. We can answer that as we sort of wind up, because we wanted to talk a little bit about some of the cultural issues associated, and some of the healthcare issues. So someone had asked about, let me just get the question. Someone is asking, what is the cause of hormonal imbalance at the age of 35 and above? So I don't know if the question is clear, Dr. Idioro.
Yeah, it is clear. Cause of hormonal imbalance, I think we need to do the screening, because sometimes, again, below the age of 35 years, you can have polycystic ovary, and this one can also cause hormonal imbalance. Again, below the age of 35 years, some people can have premature ovarian failure. It can also cause hormonal imbalance. So there are so many causes. Again, also at the same time, like after delivery, maybe somebody has bled a lot, then this one has affected the anterior pituitary gland. Then again, you will have hormonal imbalances from there. So there are a bit many causes for hormonal imbalance. Yeah.
Okay, so I hope that answers your question. And well, as Dr. Idiro has said, there are many possible causes, and it might take a while to explain all that. So you can possibly side chat. If you need her contact, please reach out to me or contact her directly on her inbox. So Dr. Idiro, as we wind up, what are some of the cultural practices that prevent seeking of care, and what are some of the barriers that you have come across and how can they be overcome, especially in our contexts in Africa and even South Sudan?
Okay, like some of the cultural practices that prevent seeking care. I think, and this is just our health seeking behavior. We always like going to hospital when we have a serious problem. So if I have those small pains, I don't go to hospital. I say this pain will go. And most of the time, like in South Sudanese community, saying this is age, I'm getting old, that is why I'm getting this pain. And again, when we come to specifically ovarian cancer, because again, like I said earlier, the presentation is non-specific. So again, there is nothing that will click into my mind to tell me that go to the hospital. I'll just say no, maybe because I've eaten this combo, now it is causing for me this haragan, yes, or epigastric pain. So now I stopped taking mula combo, I stopped taking tea. I just start excluding those things that I feel like they're the ones that cause for me those epigastric pains, instead of going to the hospital and be investigated properly for the cause of this haragan or ulcers. Yeah, I think this is one of the faults that we always have. You start excluding those ones from your meal before actually you know what the problem is. Yeah.
In terms of how our male counterparts can support their women, what would you advise? How can the men support the women in their lives when it comes to these issues with accessing health care and getting early diagnosis?
I think financially should be number one, because most of our women are financially incapacitated. So I think they need to be supported financially and encouraged to go to the hospital for at least for routine checkup. Not that until they are very sick, then we start taking them and carrying them in a wheelchair or Nangala to the hospital that this person is sick. The moment you notice that your wife's activity is actually declining, I think you better just take her for a checkup, even without complaining. But most of our men will start saying, Mara de Kalaski wa de tala kaslana. So now you're becoming kaslan instead of them becoming serious and think that this woman actually has a problem. Yeah, so I think I will just tell our men to take care of their wives and be on the lookout of their behavior. Sometimes as women, again, we try to show that we are superhumans. We can never be superhumans. So even if you are tired, you are lying down, and then when the husband comes in, you get up very fast, you go to the kitchen, you start preparing. Now they see like, you are okay. But if you are tired, actually just say, I'm not feeling well. Even if you are still able to run, that is much better than when you are not able to even walk. Yeah.
Thank you for that, Dr. Idoro. So, do you have any recommendations to healthcare workers or the Ministry of Health? And what is your vision for South Sudan in terms of the management of gynecological and reproductive health issues in women?
Okay, I think my recommendation is this. First, to my fellow women, let's just develop this health-seeking behavior. You just go. It is always good when you are told there is nothing. Even after spending those thousands, it's good to come out from there that the doctor has told you there is nothing. That one is actually much better, and will give you peace of mind for the next 1 year. And to healthcare workers, I think let us just encourage our women for routine checkup, like in our postnatal clinic after delivery. Most of these women, they come actually for the postnatal clinic, which most of the time are being done by our midwives in Juba. So I think after doing your postnatal clinic, just encourage the patients to see the gynecologist at least once after that delivery, so that at least we can do cervical cancer screening. And because we know after stopping breastfeeding, they don't show up until the next pregnancy. But again, we'll be more reassured that at least this one we have screened for cervical cancer and it is negative. So she can even stay for the next 3 years without any screening for cervical cancer. And for the Ministry of Health, I think the Ministry of Health in South Sudan has a lot of policies which have actually been developed, but I think most of them are not being implemented. So I think I will encourage the Ministry of Health and all health partners to make sure all these like gynecological cancers to be included and actively be involved in our policies. My vision for South Sudan actually will be in terms of reproductive health. In terms of the other, like antenatal clinic or the MCHC in general, in Juba, it's actually being done well, and mostly by the midwives. And what I will need to be included is actually the gynecological cancer screening. And so that one day South Sudan will have that cancer registry, and we will be able to know what cancers are actually common in South Sudan. Like for now, we don't even know. Everyone dying of reproductive tract cancer is actually breast cancer or saratan tarihim, but we don't know exactly whether it was ovarian, it was endometrial, or it was uterine cancer or cervical cancer. So I think this is the vision that I'm looking into, that one day we'll have a cancer registry and we will be able to know which cancer affects South Sudanese more than the other. Thank you, Anne.
Thank you so much, Dr. Idioro. I would love if you could just make one concluding statement, and then we can close this discussion. And I will thank the audience for joining us. Dr. Idioro, one concluding statement. Final concluding statement.
My final concluding statement for this year will always be routine checkup on your birthdays. So this one nobody can forget. Please, let's hold into that, and we will all come to your Facebook page and say congratulations and happy birthday for you. After we have known that you are safe for the next 1 year again. So this is my conclusive statement for all my lovely ladies. Thank you, Anne.
Thank you so much, Dr. Idioro. Rosemary is saying thank you, and quite a number of people here are also saying thank you so much. They are so grateful for this discussion because they have learned a lot, and they are grateful to you for taking the time to spare and give us knowledge on these gynecological conditions. And as you have said before, you are open to them reaching out to you and side chatting you on anything that might be concerning them. And you'll be able to help them as much as you can. So I want to thank you once again, Dr. Idioro, for coming on the panel and for sharing all this information. I have also relearned a lot because I haven't practiced obstetrics and gynecology for a very long time, probably more than 7 years. And thank you so much for the information, and thank you for coming on the platform. To the audience, thank you for giving us a very interactive session. We were so encouraged by your thank you messages. We were so encouraged by the questions that you're asking. It shows that you're engaged and you're willing to learn. We are so grateful for your support for the South Sudanese Women Intellectuals Forum. We'd also like to thank the UN Women that have supported us thus far, and all the other organizations, institutions, and individuals that have supported the platform. We thank people like Dr. Idioro who are willing to come and share their expertise on the platform. And thank you, Aisha, for being on the background and giving us technical support. Thank you, Tony. Tony is saying thank you, Dr. and Dr. Idioro, for such great discussions. Thank you, Dr. Tony. And we are so grateful for having you today and for you staying with us until the end of the session. So we will go ahead and end the session. Nanthon says, great informative discussion, ladies. I have learned so much. Thank you so much, Nanthon. We hope to be able to bring you more focus on women's health, children's health, and health in general. So thank you so much for joining us. Thank you, Dr. Idioro. We hope to have you again, once again, giving us as much knowledge on the platform to just assist our women and our people to understand more about women's health. Thank you so much. Thank you. So we'll go ahead and
thank you all.
Thank you, Dr.